outline will be, number one, I want to just briefly talk about the rationale in 2017 to justify the need for extracorporeal liver support. And then we'll briefly, especially for the residents in the crowd, talk about classification of liver failure, and that I think is important as we try to see where artificial liver support fits into these two forms of liver failure. So we'll talk about ALF, acute liver failure, and acute and chronic liver failure. And then we'll just a brief word about the current modalities for the sake of time. I will not go into all the modalities. We'll focus on artificial liver support, but just I'll give you the different categories. And then finally, I'll finish off with a few thoughts about where this field is going. So why do we need to think about artificial liver support in 2017? And this is data from UNOS, the federal database, in 2016. And what I want to highlight here is the tremendous discrepancy between the number of potential transplant recipients and the number of donors that are available to supply those number of organ recipients. So there's almost a tenfold decrease when you compare recipients to potential donors. And because of this massive discrepancy, you have a lot of folks dying on the wait list. And this is for all organ systems. About 18 to 20 die per day on the wait list. If you extrapolate this data to liver transplant, the estimate is about 25 to 30 folks are dying on the wait list because of the organ shortage. Therefore, as we address this tremendous supply-demand mismatch, we have to think about strategies that either A, can facilitate hepatic recovery, and that is a potential possibility in folks with acute liver failure, where they don't have chronic disease. If you support that Tylenol overdose for X amount of time, you can create a window of opportunity for that liver to regenerate and go back to square one. So I think that's option A. Option B is stabilizing those 6 cirrhotics who already have chronic liver disease and the fibrosis isn't going anywhere, to keep them stable on the wait list and prevent them from dying as they await subsequent liver transplant that is curative. So as you think about options A and B, I think this is where there is an opportunity to think about artificial liver support as a curative measure in ALF and acute liver failure, or as a bridge to transplant in particular in acute and chronic liver failure. So just a brief word. I've alluded to ALF and ACLF, so what do these terms mean for those of you who haven't thought about liver failure in a while? ALF, or acute liver failure, is strictly defined as acute hepatic dysfunction in the absence of chronic liver disease. And a good example of this is that a young patient rolls in with a Tylenol overdose. The potential good news about these patients is if you can stabilize them for X amount of time, they have the potential to regenerate their liver back to a normal hepatic function. So that is ALF. Acute on chronic liver failure, another way to think about it is decompensated cirrhosis, is what we see all the time, more commonly. And that is decompensation of pre-existing portal hypertension. Example is a hepatitis C cirrhotic. And here, if you have an acute insult, that does not result in the resolution of the underlying fibrosis or underlying hepatic dysfunction. And here, the goal is to stabilize that MELD of 35 with a goal to get them eventually to liver transplantation. So as I reflect on these two forms of liver failure, I mention these with a goal to think about how we superimpose extracorporeal liver support in these two specific contexts. All right, let's switch gears again. Let's talk about mechanistic rationale. And I'm using the acronym ECLS, that's extracorporeal liver support. So here's the schematic. So you have the liver that can develop an insult, an acute insult. It could be acute liver failure, such as a Tylenol overdose. It could be acute on chronic liver failure, ACLF, such as a decompensated hep C cirrhotic, or you can have acute alcoholic hepatitis. So 3 examples of an acute insult in the liver. When this happens, there are the accumulation of specific toxins that are hepatic in origin, if you will, that are different from toxins that accumulate in renal failure, for example. And we'll go over this in some detail. And there are 2 negative downstream effects of this toxin accumulation. Number one, it can lead to multi-organ system failure. And we see this all the time in the cirrhotic. You can develop severe hepatic encephalopathy. You can develop severe distributed shock. You can develop hepatorenal syndrome, induced acute kidney injury. And as these number of organ system derangements accumulate, that can lead to worsening survival. And so a multi-organ system failure is one downstream negative effect. The second effect can be the inhibition of potential hepatic recovery. And so you impair hepatic regeneration, and this becomes important, especially in acute liver failure. So if you were to come along and create a system that can extract these toxins with an extracorporeal liver support system, you can have a dual benefit. Number one, of mitigating multi-organ system failure and thereby improving survival. And number two, improving potential hepatic regeneration. So with a combination of artificial liver support and aggressive critical care management, we have made progress with regard to stabilizing all these acute hepatic dysfunctions, and I'll share with you some of that data from our center. So just to capsulize that first part of the conversation, you're starting with liver failure. We've defined two forms of liver failure, ALF versus ACLF. And as you think about the role of extracorporeal liver support in these two specific forms of liver failure, in the setting of ALF, you can either bridge them to intrinsic recovery, or you can bridge them, if the damage is too far gone, to liver transplant. And we've done both of these forms at Emory. In the chronic setting, when you already have a cirrhotic, we have successfully bridged folks to temporary stabilization. So take that MELD of 35, bring them down to 30, prevent them from dying, and eventually bridge them to life-saving liver transplantation. All right, so just a brief word, switching gears again. Two forms of extracorporeal liver support. We'll focus today on artificial liver support. And under that category, you have the MARS system, which stands for the Molecular Adsorbent Recirculating System. I would think of it as an albumin dialysis system. And number two is high-volume plasma exchange. And this is exciting data. We did our first case a couple of weeks ago with regard to high-volume plasma exchange with some pretty remarkable effects. I want to share that with you as well. So we'll focus our attention on these two forms. Just for the sake of completion, there is another evolving form of liver support, which is called bioartificial, i.e. you actually have hepatocytes in the extracorporeal circuit. And this is as part of a phase 3 study that is happening currently, and Emory is one of the sites, looking at using the ELAD system in severe alcoholic hepatitis. So we won't talk about the ELAD system, which is a form of bioartificial. We'll focus on the artificial support system. So let's sort of dive into MARS. And this is a schematic on the left of the MARS membrane. So as you reflect on this diagram, I would draw a contrast to CRT.